Achoo! Just joking. We're moving into respiratory diseases. I'm sorry, I'm such a dork. So, Dr. DeChavo, back with you again. We're going to start to move into bread and butter respiratory diseases. And I'm going to fly through some of these because a lot of them I think you have dealt with quite a bit. As always, if you have a question, shoot me an email. So, viral rhinitis and the common cold killer, right? How many times do we get this? Several times a year. I read somewhere 2 to 3 times a year for an adult, 6 to 10 times a year for children, which is probably not surprising for all of us who have kids because they do get colds often. Although as my boys get older, they get better with it. Now, the problem with viral rhinitis is that it thins the membranes and it makes us more susceptible to a secondary bacterial infection. So if you get a really bad cold and it progresses and it's viral and you're blowing your nose a lot and you don't take care of yourself, those membranes can be damaged and we're more prone to getting a bacterial infection, which may progress as this goes on. Incubation period is 2 to 3 days. This is why probably everything spreads so much, because people don't know they're sick and they're around people and they spread it, unfortunately. Manifestations, I went through with this lecture and really pared down what they included with the manifestations because I think it got a little crazy in cardiac. So typical cold symptoms, we all know what this is, you know, the runny nose, exhaustion, etc. Rhinosinusitis. So once again, if we get that viral rhinitis, we thin the membranes, we can get either a virus or a bacteria that actually go all the way up into the sinuses. And what is more miserable than a sinusitis when it progresses? The exudate will collect, you know, an exudate is a fluid that will have more infectious substances in it rather than a transudate, which is going to be a little bit more serous and clear. And it'll block those sinus cavities, causing really bad paranasal facial pain. And we as clinicians, I can't because it's not my scope, could actually transilluminate that and see a little difference from side to side, but even quicker and more efficient is a little bang, bang, ouch. You know, they have immediate withdrawal symptoms because it's so tender when you have the sinus infection. And it's usually in that maxillary, which is just below the eyes, or that frontal, which is just above the eyes. Epiglottitis is going to be inflammation of the epiglottis, which can be life-threatening, especially if it swells over the trachea. So there's multiple causes, but the one thing that your book mentions, so we'll stick with, is type B, influenza. And I'm telling you, I think this happened to my son the other day. We were getting ice cream, and he was walking, and he fell literally right on his throat because I think he had something in his hand. And he had so much pain, and he said that his throat was closing. And I thought, oh my gosh. So I immediately gave him Benadryl, you know, because God forbid he got bit by something. I don't know. And looking back on it, it calmed down after a while. And once the Benadryl kicked in, he said it still hurt. I gave him some Advil, and that calmed it down. I think he just jammed his voice box, and I think maybe his epiglottis got a little swollen. And, you know, it was a little disconcerting for him. It was definitely a sore throat, which would be caused more by sickness, but I think it could be caused by trauma too. But don't quote me on that. Laryngitis, we know what this is. So the larynx is your voice box. I'm going to, I already showed you a picture of that, and we saw how those vocal folds come in together, and they can just get inflamed. You could get this from being sick. I've had this completely just unto itself where I really wasn't sick, but something obviously infected the larynx, and you lose your voice. You know, it could be if it's correlated with a cold, you could have some exudate and some running nose, etc. But if this progresses, it can actually show on an x-ray as a narrowing of the area just below the larynx. It's called Steeplestein, I believe it is. I have it in the notes a little further, and that can narrow because there's swelling there. Okay, so let's practice. I have some interesting pictures here. So to get you a little bit oriented, we're looking at, so these are the nasal conchae. So this will be the nasal conchae here. So this will be the nose, the nasal cavity, right? And these are your eyes on either side. So look at this poor thing compared to here. What do you think this is? Now I think you probably know it. Black sinus. A bad one at that. No, thank you. Now this, how do you know where to look? You look at the arrow, right? You look at the arrow here, you can see the arrow, you can see the trachea. It is important to always spot the trachea when you're looking at an x-ray. And the trachea should be midline, and it should be dark because it's full of air. And as we follow that trachea up, so here's the trachea, you could see that narrowing there. So what do you think is happening there? Laryngitis, and that's actually presenting as a steeple sign when they've taken that picture. And it's called steeple sign because it looks like a church steeple at the top. This one should be super easy for you. What are they doing? Transilluminating. I shouldn't even put that in, right? Of the sinuses. But once again, just palpation with those sinuses can be so painful. Now, I did also want to show you that that is a maxillary sinus. I'm sure this is all I have for you, but just as a refresher, those are pretty big sinuses. When I teach this in my lab, I pull out human bone skull. And I mean, it is pretty deep. So you can get a fair amount of fluid and exudate in there. It's very uncomfortable. And then also in the frontal bone, we have much smaller frontal sinuses. And these are known as paranasal because they are obviously around the nose. So looking at this may be a trickier one. I pulled this one offline. So take a look at this. Think about where it is. Look at the picture on the left, which is normal. Look at the picture on the right. Out of what we've just spoken about, what do you think this might be? This is a little bit tough. Epiglottitis, okay? And there's swelling and inflammation and whiteness at the arrow compared to normal, which is on the other side. That one's slightly tricky. Okay, so laryngotracheobronchitis or laryngotracheobronchitis, I'm not sure how you say it, people say it differently, is group. Okay, so this is a viral infection in children, can be from influenza, adenoviruses as well. The larynx surrounds, the airway narrows, you can have obstruction, you could have respiratory failure if it continues. And they have that seal-like barking cough, hoarseness, difficulty breathing, giving you that inspiratory stridor, and obviously pain with breathing. Bread and butter, right? If you have any questions about that, let me know. Excuse me. Acute bronchitis, bread and butter as well, right? Inflammation, the tracheobronchial tree or the large bronchi, viruses, bacteria. This could be from irritants, allergic reactions too. Kind of buzzing through these because I feel like you guys probably know these. The flu, eek. So this is viral. This is why this is such a bugger to get rid of. And it's highly adaptive. We're always guessing at the immunizations to see which strain we can immunize against because it changes so frequently. So the three subtypes, type A is most severe, most common in the US. Type B is less severe. Type C, I'm so sorry, excuse me, usually causes small outbreaks. So flu season, we know this, I'm going to buzz through all this, is through October and March. Incubation date of 1 to 4 days, which once again gives us plenty of time to get exposed to people before they have any symptoms. So can cause problems with children, elderly, and immune-compromised people. There's your list of manifestations, all stuff that you know: fever, headache, chills, dry cough, body aches, sweating, malaise, extreme exhaustion, in other words. Moving on. So bronchiolitis is when we get that inflammation down into those bronchioles, and this can be due to that respiratory syncytial virus, or RSV. I think people reference it more often. And this can cause problems, especially in young children who have asthma. I know somebody whose daughter had this, and combined with her asthma was a really big problem. She had to be hospitalized. If those bronchioles close, you can actually either trap in air that'll become stagnant in the alveoli, or you can block the air from getting in, which can actually lead to atelectasis or lung collapse and respiratory failure. So cough, wheezing, rapid and shallow respirations, and dyspnea can be dangerous stuff. You want to make sure you get people checked out if they start to progress. Let's do a quick question here. So which of the following is the best description of respiratory diseases and their correlations? So bronchiolitis is found in the main bronchi. Flu is a bacterial infection. I know you're like, really? You just rolled your eyes, but hey, you know, throw you a fish and a bone every once in a while, whatever. So bronchitis is inflammation of the tracheobronchial tree of the large bronchi. Laryngotracheobronchitis never causes difficulty with breathing. What do you think? That one should be pretty easy. Moving on to pneumonia. So this is an infection that will inflame the alveoli or the surrounding tissue of the alveoli, as opposed to pleuritis, which we're going to go over, which is going to be in that pleural space. So with pneumonia, we could have infections, we could have an injury, we could have pulmonary secretion stasis that's staying in the lungs and infects the inside of those lungs. We can have viral, which will be mild, but this can lead to secondary bacterial pneumonia. Okay. And bacterial is a more common. This can be from strep, and this causes some more problems. So, different types of pneumonia. We have aspiration pneumonia. So, this could be that they have inspired something after vomiting. They could have inhaled something. There could have been an inappropriate gastric tube placement. You name it. I'm sure you know a million examples of this where something has been aspired into the lungs that shouldn't be there. And obviously, once it gets in there, it's going to have an immune response at that location, which will send the immune cells into the surrounding tissues and alveoli. So lobar is going to be in one lobe. Bronchopneumonia is the most frequent type. This will be through several lobes. Interstitial is, instead of being in the alveoli, it's in the tissue surrounding the alveoli. So most common by viruses and commonly by bacteria. I would think there's a little crossover with regular pneumonia too. It's not going to just stay in the alveoli. It's going to get into the interstitial tissues as well. Nosocomial will be developed after a hospital admission. I'm sure you know that, as opposed to community, which would be out in the community. So this is a nice list of comparisons of viral versus bacterial. I'll let you read through those on your own. Once again, I'm kind of buzzing through because I think probably most of this is pretty familiar. Now, Legionnaire's disease is a pneumonia caused by Legionella pneumophila, sorry. Sorry about that. So, which thrives in warmest environments, particularly air conditioning. So, this is at a higher risk and immune compromised, and you should test for it. God forbid they get it. Okay, so pneumocystic CARINII, caused by a yeast. This will be opportunistic, so we would see this in populations that have been exposed to HIV. And you could test this with a sputum culture. I have to turn my voice on, sorry. Now, you would probably not realize this unless somebody is immune compromised. So you would test their sputum to see if they had been exposed to it. Your book is now calling it Jurovecii. Correct me if I'm saying these incorrectly. I apologize. So, I don't know. You probably hear one or the other. So complications, obviously pulmonary edema, lung abscess if things stay in the lung long enough, and acute respiratory distress syndrome. So productive or non-productive cough, depending on whether it's viral or bacteria, exhaustion, chest pain, difficulty breathing, fever, chills, crackles or rails, and then a pleural rub. So diagnosis, obviously through chest x-ray. Hand washing is just so important, as we all know. Avoiding crowds, vaccinations. I took some things out there. I can take that out. Coughing, deep breathing was an interesting prevention, I guess, to keep the lungs open and keep things moving, because you don't want things to stagnate. But I thought that was cool that your book included that. And obviously smoking cessation. If any of you smoke, my goodness, you better quit. That's all I have to say about that. So regardless of the cause for our question, I can't even say cause today, for our question time, pneumonia causes fluid buildup in the lungs, both alveoli and surrounding tissues. Bing, you got that. So tuberculosis has been something that has waxed and waned over the years. This was fairly controlled until recently, and I think from what I'm hearing, we're seeing a little bit of an upsurge in contained populations, elderly that are in nursing homes, jails, etc. So, and then we can have the resistant strains that develop an immune compromised. Most frequently will occur in the lungs, but can spread to other organs. It mostly occurs in the lungs because it's carried by those airborne droplets. It's caused by Mycobacterium tuberculosis. So let's talk about the stages of this. So the primary infection is when that infection or bacillus enters the body, and your body launches this huge immune response to it, where macrophages will engulf it, but then that also causes a local inflammatory response, and you could get what are called granulomas, which is a deposition of those inflammatory response cells, which can eventually start to harden with calcium around them, and they will continue to form until they get a caseous necrosis in the center, with a calcification around it, and then the surrounding inflammation in the tissue. So when you get that caseous necrosis and the calcification and the surrounding tissue inflammatory response, you get what's called a Ghosn complex, which is going to look like a larger calcified lump. The granulomas can get a little bit of calcium around them and be widespread. I'm pretty sure that I dissected a cadaver that had the granulomas, and when you felt his lung, it felt really crunchy throughout the whole lung. So our guess was, without opening the lung, because it kind of freaked us out a little bit, I'm sure it was beyond dead, but that they were granulomas formed from the tuberculosis infection. So these bacilli can remain dormant for years, as we know. That's why we do the testing, right? The MAN2 testing, and it can be asymptomatic. But that patient will test positive for it, even if they have the dormant ones. So a secondary infection will be reactivation of those dormant bacilli, can spread to other organs, and then the symptoms will develop. And, you know, it's exactly what you would think: the productive cough, spitting up blood, coughing up blood, night sweats, which is always a bad sign, period, fatigue, unexplained weight loss, anorexia, which would go along with the weight loss, okay? So your skin test would be positive. A chest x-ray obviously would show either those granulomas or the Ghosn complex. You do a CT scan as well, and a sputum culture will be the final diagnostic that will definitely confirm it. So let's practice some things with TB. And this one always grosses me out. What do you think is in that outlined tissue? That's going to be your caseous necrosis. That'll happen. And then that'll get encased by the calcium that we spoke about earlier. Okay. Now, I know this is a little difficult to tell. What do you think if we're looking at the lung fields? might be happening here. Okay, those are tubercles, which are those granulomas that form, and then you get the calcification around it and the inflammation. It's actually called tubercles, and that's where tuberculosis gets its name. But if you say granulomas, I would agree. Now this one is going to be a little bit more definitive. That large white structure that's just above the heart is going to be your gone complex, where you get those multiple factors combined together to form a large deposition in the lung tissue. And everybody's like, I know what that is, right? Positive TB skin test. Okay, so moving on to asthma. So this is a chronic disorder. There's intermittent flare-ups that will come and go. And what happens is there's spasms of those bronchioles that we spoke about. It can affect your bronchi as well, but the bronchioles are the main drivers with asthmatic conditions. They shut down and it gets very difficult to breathe in. It feels like the patient is breathing through a straw. So there's a variety of triggers, from infections all the way to smoke. It's pretty common. Asthma, so different types. Intrinsic is not an allergic reaction to smoke, infections, cold exposure. It's something inside that patient that triggers their asthma. Don't drive yourself nuts about that. Extrinsic asthma is going to be allergens triggering the response. This is something that I have. I am allergic to everything. Everything. Dust mites to dogs. I'm allergic to it. I'm exposed to stuff all the time. Sometimes I think if I'm taking better care of myself, I can control it. Sometimes you're going to have more of an inflammatory response. So IgE is going to be the immunoglobulin that will trigger this response. Nocturnal asthma will happen between 3 and 7 a.m. Could be related to circadian rhythms. There's also different releases of hormones over the night, such as epinephrine. But mainly the driver will be histamine. Histamine levels will increase, leading to that bronchoconstriction. Exercise-induced asthma usually occurs 10 to 15 minutes after an activity or even into the activity, and symptoms can linger for up to an hour after. Drug-induced, frequently caused by asthma, which can stimulate leukotriene release. Leukotriene is what's called a paracrine. It's a locally released hormone, which is a powerful bronchoconstrictor. In medicines, I don't do drugs, so I don't teach drugs, but leukotrienes, I can tell you just from experience, there's different asthma medications that focus on those leukotrienes to inhibit them. So wheezing, shortness of breath, etc. I think you know that. So status asthmaticus, oh my gosh, I can't talk today, I'm so sorry, is life-threatening. So this is a prolonged asthma attack. I know somebody who passed away from this. She just was home alone. She couldn't get control of it, and she passed away, unfortunately. So it's something that you want to take care of, especially if it's progressing. Now, I found a really cool little video that's about bronchial thermoplasty, and they actually go in and they heat up those bronchioles, and it opens them up, and it allows people to live with asthma in a much better way. So go ahead and check that out in your supplemental media. So this is a picture of normal on the left, and then the bronchioles on the right. And you can see that smooth muscle contracts. It narrows the lumen. The lumen is just the opening in the center of that tube. And it also deposits mucus in there. So you have an overproduction of that mucus. I'm so sorry, I'm hopping around on here. Okay, so we are going to take a break at that point and pick up in the next video. If you have any questions, let me know. I'll try to have a cup of coffee and turn my mouth back on so I talk better in the next video. Thank you so much. See you in the next video.